Get started. Good morning and happy Friday, everyone. Welcome to Friday Palliative Care Chalk Talk. My name is Patrice Fadell. I'm your moderator for today. Today we have three guest speakers to talk to us about community and home-based palliative care operations and design. Tom Gualtieri-Reed, Donna Stevens, and Lindsay Van Gumpel. So take it away.
Thanks, Patrice. Hello, everybody. My name is Tom Gualtieri-Reed. We'll do some quick introductions of ourselves so we have a sense of who we are, and then we'll jump into today's topic. I am a consultant. I'm not a clinician, but I've been working in healthcare for over 30 years. A lot of my work over the last 10 or 11 years has been focused in on helping programs of all settings, all sizes, and all shapes build out palliative care in home, clinic, and hospital settings. Got a chance to work with all across the country. I'm based out of Chapel Hill, North Carolina, but work all across the country and have both payer background as well as provider operations and hospital background as well as clinic. Donna, would you introduce yourself, please?
Hi, Donna Stevens. I also have been working in the admin side of things. I did start out clinically as an occupational therapist, but quickly kind of went into some leadership, first within inpatient psychiatry, and then the second half of my employed career was with palliative care at Lehigh Valley Health Network, developing a full palliative care continuum there. We really kind of gained some interest from CAPC in our home-based team specifically, and really did quite a bit of work to try and help others with how to develop that, and that's been in existence since 2006. So what I've been doing since then is consulting with CAPC. I do virtual office hours to talk about home-based issues, specifically with leaders around the world now, CAPC not only nationally, and also educate leaders in palliative care administration, do coaching and all kinds of fun stuff now.
Thank you, Donna. Great to have you here. Lindsay.
Hi, good afternoon or good morning, everyone. I'm Lindsay Van Gumpel. I am the executive director for Advocate Aurora's Advanced Care at Home program. Included in that is both home-based palliative and home-based primary care. So I was just telling Donna and Tom earlier, I enjoy what I do. It's certainly fun. A host of challenges, so I'm excited to talk with you all today just about some of the considerations around operations and design, and certainly no one size fits all for any area. Thanks for having me.
That's great, Lindsay. It's really been a pleasure. One of the things that Donna and I do is we both work consultants to CAPC, and so we get a chance to do different programming. And so part of this was really an opportunity to connect up with you all and Lindsay to kind of really hear what you're working in your home-based programs. And so today's session is really to kind of do kind of a speed round of engagement with Lindsay to kind of hear some of the things that you're doing. We'll give some tips and guidance, and also at the end we've got some resources for you as well too. But just to set some quick context for this, this is hard work. Figuring out there's a huge recognition of the need to take care of and support patients and family caregivers outside the hospital and clinics and wherever someone calls home. So we know that there's a need out there. We know there's developing clinical and payment models around how to do this and do this well. I just highlighted that Hawaii Medicaid just proved this past year a palliative care benefit for home-based and community-based. And our hope over time is that becomes a payment model that others might follow. There's a lot of other folks doing this, but part of the challenge and dilemma in this is a financing issue. So I just want to kind of name that. But today we're really going to focus in on the fact that in home-based models, there are so many factors around staffing and operational, financial, and quality issues. And so we're just going to spend some time brainstorming strategies for kind of addressing those operational and program design challenges, and are going to anchor to some questions that we worked on to help feed us in this discussion. So the questions are really going to anchor to an element around really thinking about the needs assessment and defining the why, thinking about care team design, and then the logistics issues around that as well too. So with that, what I'd like to do is start with my colleague Donna. Donna, you've done so much planning and work, and you've been a huge advocate of the step of needs assessment. Can you just give us a couple quick insights about the importance of that, and also how you use it during the journey of figuring out how to do an effective home-based program?
Sure. So most people are very familiar with what would be inpatient palliative care, the consult service that happens at, I don't know, 90 or 95% of the hospitals with 300 plus beds at this point. And it is very common. And so within the confines of a Medicare A environment, it's very kind of standard in terms of how that's grown. Surely there's differences in terms of the team structure and kind of maybe focused patient population. But in terms of how it's structured and how it's paid for and those kind of things, it's kind of already built. But with home-based and anything in the community, it is much different. We have to think about, why it is important and what are we really focusing on and who might we partner to do that. With home-based, it's not going to build itself and it's not going to be build it and they will come. It really does need to be foundationally sound from the start. You need to have partners in this work. You need to understand who the funders are and what's important to them so that there are combined goals that we share our interests with our partners. So that looks like, when you're thinking about a home-based program, what kind of things will be offered there and how it augments and does not overlap with resources that may already be in the community. There are many services now that emanate out of a hospice or a home health agency. And it is tricky to understand how it overlaps versus a standalone kind of how does home-based palliative care make its own need. In order to do that, you have to be clear about what the focus is. And in order to do that, you have to do a needs assessment. So you have to look at, what is the healthcare gap wherever you're talking about and whatever geographic area, what exists there already? How can you look at partnerships? There aren't home-based teams and access in a lot of places, but there are other home agencies that may be helpful to partner with to fill this gap of providing even more care to those who with serious illness in the home. But you have to be clear about what your scope is. And so again, back to the needs assessment, you have to think about what's important to the people that might refer to you. So with us, we started with a very exploratory needs assessment and really looked at what was happening in the healthcare community. And it was that at that point, the PCPs were completely overwhelmed. And so we went to our PCP colleagues and kind of said, how might we help in the home? And so they became our primary partners and referring entities. And so we developed what ended up to be a co-management model with them. But again, it was all based on this partnership and what was important to them, that we take care of those patients that took an hour and a half in their practice and they didn't feel like they were helping. And it really grew out of that. So I'm a big fan of pilots. I'm a big fan of looking at what is a specific need that you can show impact with and then grow it in strong ways. And so it all starts with a needs assessment to understand who your partners are, what kind of payment systems are possible, what kind of geographic territory might you cover. But there's a lot that goes in. I think you're going to talk about this, Tom, is scope, because you can go into homes, which is very much the patient and family's environment. And you have to show impact, but it has to be something that would also be important to them. So they're a primary partner, and if you will, stakeholder as well in the success of this program, whatever you're going to develop. It all goes back to the needs assessment. We have to understand what's important, what kind of gap you're going to be filling, and how might you do it with the resources that you may be able to gain.
Thank you, Donna. In a minute, Lindsay, I'm going to ask you to kind of share your kind of what have you built and how did you go about some of your steps there. But I just want to reinforce, not only the points that Donna made, but my experience too. I think about the fact that number one, you're also building relationships in that needs assessment process, and those relationships become very, very important over time. For example, if you're out doing just discovery with your home health partners in the community, you're also building a relationship with them, and later on, that relationship can be used to help share resources. So I just really, when I do my planning and guidance to folks, those relationships are very important to you as you figure out scope and design and staffing. It also is important in finding funders in your own organization. Like, who cares is also who's going to help fund this. And so that also is an important part of those relationships. And the other just big thing in my mind in this process is that it's not a one-time event. That you're kind of always doing discovery. And sometimes you hit a bigger point of inflection where you get really stuck. And you sometimes have to go back and do a little bit more of a needs assessment, reassessment of kind of where things are, recalibrate and go back in. So I just, that it's an ongoing process, but it's not analysis paralysis. At some point you have to pick a plan and move with it. And that's the piloting language. I thought that Donna was great. So with that, Lindsay, I'd love to hear your reflections on kind of the why and what you're offering and kind of what you discovered as you've been or are continuing to discover as you're refining what you're doing.
Yeah. No, and thanks. I really appreciate how you line that all out, Donna, because I couldn't have said it better myself, really, of just how you're getting to the needs assessment and again, defining the why, because it'll, as folks create a program and have a strong why, it'll continue to help have that conversation no matter the market. And I know we'll get into it, right? Rural versus urban, it might change the overall care team design, but it'll keep coming back to the why and be your driver forward on who are your key stakeholders, what are people really looking to get out of it. I would say from Advocate Aurora's perspective, another lens of the why is the organization started to get into some of the managed care business sooner rather than later, than I would say some of the rest of the nation. And so it was really a responsibility, but even just, I'd say, an opportunity as far as, we know we need to manage our patients, manage them well, and provide them the correct resources. And so it started certainly on a journey of what are those resources? Are we having, advanced care planning, goals of care, discussions to really help patients understand and make informed decisions about how they want their treatment to go. And so we kind of have this phrase of the what matters most with the patients as a stakeholder of, making sure they have a seat at the table so they do have an approach and a philosophy that lends them to be somewhat in the driver's seat as well, as far as, really being informed about the decisions that they're making. So that's part of the reason why Advocate Aurora went down the route of, we know we're responsible for these patients. We have an opportunity to meet them where they're at. And that kind of comes into, so then how do we fund it? Really, what are the barriers to meet them where they're at? And so just like you said, Donna, it did start with a lot of conversations with our primary care partners as far as, what inhibits you from feeling like you can impact. And it's not patients can't always get in. If they can get in, maybe their spouse or key important people in their lives can't attend with them, and they really need them there in order to make some of those difficult decisions or just have more of that family type conference. So, it started to lend well to, we could meet them in their homes. We could meet them where they're at, where they're comfortable, build a relationship from that standpoint and start down that route. So I would say that's a little bit of where it started, again, from the primary care mindset, and then also with our hospital partners as well, as far as, we're discharging these patients, we're doing those inpatient consults. How can we keep this conversation going and not have to put it on our primary care docs or keep it going in that vein or that symptom management, et cetera. So that's really where it continued to develop. And it started very small within Advocate as far as, a couple nurse practitioners, and I know we'll get into care team design, but a couple nurse practitioners and nurses, and then just continuing to learn and grow from there.
That's great, Lindsay. And I think your concept about kind of what matters most, kind of like a philosophical mentality as you go to do this work is a wonderful filter. And the idea of starting with those stakeholders of like, where's the need and kind of building from there. With time, I want to move into that first topic. I mean, one of the challenges is figuring out the right care team design, staffing and workload expectations in the home-based settings. There's a lot of factors that go into it. A couple, obviously, is scope of practice. Are you consult only versus co-management? Do you have a full IDT? And again, to Donna's point, in some cases in our reimbursement system, it's when we're doing fee for service, we think billable providers, but there's so much that can help the whole team work well if we have true interdisciplinary team support as part of palliative care, because those psychosocial and spiritual needs need to be accounted for. And then certainly elements of, new visit workflow can adjust things and have some create some wild cards in your work as well too. So when you think about staffing and workload expectations and kind of the care team design, Lindsay, what have been a couple of your challenges or just kind of key findings?
Yeah, I'll say just, high level. Right now we run this program in both Illinois and Wisconsin, and there's even state limitations of what certain roles can do in certain states, which is certainly part of the consideration that one would need to take into account, right? What can advanced practice clinician do, what they cannot do. So we started to go down the route, I would say, at least when we started in Illinois, of it really started more consultative in nature. And again, that's because it was newer, piloting it out, trying to get feedback, does this work? Does it not work? And as we built some of that, I would say relationship, it started to move into co-management, because then it started to, I would say, the light bulb went off as far as, hey, but if you're in the home, like, yeah, we know you, we trust you, we know what you're trying to accomplish, you're managing this, go ahead and order it. You don't have to, kind of continue to, I would say, not continue to not check in with folks by any means, but there's certainly a certain level of freedom that comes with that, of being able to, right, our goal is to treat in place, and sometimes that means you have to make decisions fairly quickly. And so that's why we did go more of the advanced practice clinician route of they're doing that initial assessment, they're really enrolling the patient. Like I said, there's really no one size fits all. I know there's a host of models that have more of a registered nurse function, or even higher level of social workers. So how we have it is really there's, I wouldn't say necessarily a pod, but there's different ways to refer to it as geographically based teams that would comprise a nurse practitioner, a nurse case manager, and a social worker. And so they're really charged with, you're going to have a panel, and there's we've kind of gone through the gambit of what's an appropriate panel size. And again, it's more so around, here's what we think is clinically safe to manage, especially if you're on PTO and somebody's covering your call and having to manage your team as well. So big picture of what we feel is clinically safe to manage. And then if we're starting to get a little tight on that panel size, how can we add in another nurse practitioner, or maybe adjust some geographical zip codes so that it does stay manageable and safe. So again, pretty quick on that response, just because I know I want to be mindful of time, but anything that you want to add, Donna, as far as other key considerations to think through? I know we could spend a whole day on this.
Yeah. Can you hear me?
Yes.
Okay, very good. Well, Lindsay, I would just echo everything you said. And I loved, starting out with relationships, because that's what it all is about, right? Because some relationships, like we started out, going and meeting with the PCPs back when you were allowed to actually take some time from their schedule, back in the good old days. And it was very much, how can we help with this panel of patients that keeps you up at night, kind of as generic and simple as that, but that was very meaningful to them. And then we kind of figured out, what does that look like in the home, and how can we think about how we can really expand their, their impact. And with that relationship then grew what you were just describing so beautifully. And that is, they start to trust your practice patterns, and they start to feel fine about you managing certain disease states or symptoms, both. But we never wanted to feel like we were alone in the home. The home can be daunting, and that you can encounter all kind of emergencies that you really feel very ill-equipped to manage. And so, yes, you can call the ambulance and send someone to the emergency room, but you're there and you do want to impact in a positive way. That's why the ones that are non-practicing and consult only, it gets a little frustrating, I think, for those practices. Those are people I've talked to, because you want as a clinician to be able to impact. But in terms of how you decide that, I think it is back to what's needed, and for us, it was the directive from the network was to, how can we manage patients in a more, as you're saying, clinically safe way. And as you described earlier about, patients just having undue burden trying to get into their practices alone, is enough to really make a real impact. The other thing I think about is, the level of symptom management has to be articulated pretty well. We had, as every clinician who has some level of experience, a nurse practitioner, APC, or an MD, of clinical background, and they're more comfortable with certain disease states or issues. We had a wound specialist that was in the wounds for 20 years, so nothing really fazed her about wounds, but others kind of were a bit intimidated by it. So you want to make sure, as you said, that the nurse practitioners or whoever feels clinically safe in the home, but what other safeguards and supports can you build in that make that important or feel like it's sustainable? I want to speak about sustainability, and I'm afraid I'll forget. I don't even have anything to write anything down. Sorry about that. But it is this whole notion of how can the clinician survive in the home and the patients do better or feel better supported. And I think that with symptom management, with oncology, it looks a lot different than what it will be with organ failure and potentially dementia and frailty. And so understanding the skill sets needed for all that you're trying to do is very important, and understand the scope of what you're trying to do. Not only the scope of the role, like we were co-managers I mentioned, but it's also what kind of disease states do you feel comfortable that you can impact. We kind of said that from the beginning we wouldn't take primary psych, but certainly secondary, because many of those patients become not, later in life become much more medical illness burdened versus psych burdened. And so we kind of manage them later in life. But I have to say that, with the primary psych diagnoses, those people also have life-limiting serious illnesses that need support. But it wasn't something that we felt we had the expertise nor the support to do. So we kind of cleared that barrier pretty early on. But I think those kind of things need to be articulated well. And then, again, if it's kind of a free-for-all, we went by regions, not necessarily pods, but had, much like you're describing, Lindsay, a nurse practitioner led care, and then had social work, nurse, and MA support, and dosed it according to the panel size. And so I want to speak to sustainability also with the team, because I feel like this work is so nuanced. When you are in the home, you may be the only clinician that person and maybe even patient family sees. And so you leave and feel like, they won't be supported again until you revisit that home. It can be very intimidating as the prescribing clinician. And so we wanted to make sure that we always had a partner in this work, and that meant the PCP or the subspecialist, whoever's referring to us, that we could always call and say, this is what's going on. Now, we shared an electronic medical record, which is also a very important element when you're thinking about constructing home-based, is how are you connecting to other clinicians in the care, and to make sure that what you see in the home is represented in the information that they may encounter in the emergency room, say if they enter there. That it's not lost, because the information that happens in the home is so much more than head in the bed or head, whatever somebody comes in with. And the social determinants of health really need to be represented. And so that's really a big part of a benefit of what happens with home-based palliative care. Sorry, I went on there a bit.
Donna, no, that's great. I think your point about sustainability is also something you can't always quantify in staffing and workload needs. And so figuring out how to account for those and how to think about the full team, as well as the moral distress and other things that these, redesigning those. Marty, a good question. It actually does tie into something here. And my reflections were a couple things. Number one, to Lindsay's point, you're always trying to match kind of the practical, like what's the right thing to do at the practical moment with your staffing capacity, right? So when you think about moving from a consult only, and you can say, look, you start doing scripts, it's like, sure, yes, and what are the resources we need to do to have the appropriate follow-up for that? What's the appropriate resources we need to make sure we've got an RN that can be tracking those? And so that does require another point of inflection of program design that often does require you to go back and think about your staffing plan and think about what's the capacity of patients you can see. And you're going to be following those patients possibly for longer. So now you've got, fewer new consults and more follow-ups. Like that all can affect your design. And you just need to kind of pause and reflect on that. So I just wanted to name that as like a really important.
Could I add something onto that, Tom, really
Please.
quick?
Yeah.
I think just one other thing, if anyone's listening to this kind of in the vein of thinking about maybe starting something in this space, I would encourage you, in the realm of care team design, don't overlook and don't underestimate the support that's needed. I was just really talking about the staff that's in the field. There's a whole host of, I would say, carrying out the work behind the scenes type stuff, as far as we've got intake individuals who are answering, incoming calls, working incoming referrals, our LPN care coordinators that are also helping support, if referrals are coming in, patients are moving around, getting admitted, discharged. I feel like sometimes when we talk in general about, programmatic things, we can often lean towards the staff in the field and what they're doing. But I would also, just continue to stress, like there's a lot of support that's needed for them to do that work in the field, and don't underestimate it.
Can I add something? I don't know if I'm mic'd at all.
Yep.
You're on. Okay. Yeah, Lindsay, such a great point. I really feel like that needs to be echoed, because we have our nurses there. They don't go out into the home. It's only the clinicians and the social worker basically that goes to the home. So they are in the office doing triage work all day long. And so that means, like Tom, you mentioned about follow-up. Exactly. We have to be following up, especially when we're writing these scripts, to understand what's happening in the home. And they have to have a place where they can call to understand, what's happened and what they might need to do differently. So they need a point of contact. And we always feel like Oasis, that was the name of our program, is a place where people answer the phone, where other practices go to like a phone tree. And that kept people really very closely linked. And I would say, they felt more support. But it really is around this whole notion of pain and symptom management. Can't just be you're giving a script and that's it. There's a lot more to it. And our nurses are just expert triagers, and really understand what needs to go to the nurse practitioner, what they can manage on their own. So I'm so glad you brought that up.
Yeah, and I think we've got a couple questions coming in. I think this is also feeding into an important discussion around, when you think about geographical coverage and scheduling and really having those elements that are so critical to the rest of it happening, having that effective triaging role, having that effective scheduling mechanisms, having those elements. Again, one of the challenges is that, you're doing workflow trying to get permission from a patient, but you don't see the patient. So how does all that happen? There's a lot of logistics behind it. So that leads into this question around, one is the question Marty was asking, like, how do you prioritize which patients are appropriate at certain times, and kind of what's your kind of stratification tool that you use to help think through the dosing of different services, because that drives a lot of logistical issues. And also the other question, kind of somewhat related though too, is, so much of this is about allowing patients to remain at home, unnecessary stays in hospitals. But so you have to do some element or balance of education and discussion time with kind of the standard assessments. And so, you can't do that on every single patient. So I guess my question for the two of you as we kind of finish out here is we kind of match kind of logistical issues, team design, and best use of resources. What's a helpful tip on stratifying patients, and then how do you balance appropriate education time with assessments and who needs what for those levels of kind of high impact needs that aren't always able to be planned for and sometimes not always paid for in our payment systems. So maybe I'll start, Donna, with you on little reflections of kind of prioritization and the scope of education versus just a lot of assessments.
You're saying education within the actual visit?
Yeah, or
okay.
Outside of it. I think, the time spent to allow for discussion and education. In addition to the standard assessments.
Yeah. Okay. So, you can have, and I'm not kidding, you can have assessments that would go on for 4.5 hours when you're in the home. So you have to have guidelines. You have to have some sort of parameters in terms of how much time you're going to allow for an intake assessment. I want to also make sure that I'm saying that, so our nurses our RNs do an intake. They do all the first contact of the patient to understand, kind of from a patient and family's perspective, what's happening and how we might be helpful. And then the nurse practitioner does the first home visit, and that is scheduled for an hour and a half. And so we need to make sure that there has been preliminary information enough so that the nurse practitioner feels prepared enough in terms of going in and at least having some idea of what's going to happen there. And within that hour and a half, it certainly has to be that there's some education around disease states, symptom management, those kind of, and especially follow-up. We put a lot of that into the follow-up information that we have for patients, and we use the portal, which is helpful for patients and families to kind of make sure that everyone sees the same thing. But in terms of time limit and how you decide who needs what and the dosing of that, it all is going to be in terms of the clinical assessment when they're there, in terms of, do we need to take a lot more time than what may be allotted for that one and reschedule the one that happens later. That stuff happens all the time. There's always this notion of I have to prioritize how I'm spending my day and understand who may be more vulnerable today. And that goes back to having consistency in terms of clinicians seeing the same patients regularly. It really does help. Not to say that others can't back up. We do have two nurse practitioners covering different regions. So technically you have a backup that someone else is sort of familiar with what happens with that. But it's also something then that's taken back to the whole IDT to review and help with some of those triaging elements. So we review patients every week, and those patients that someone was a little bit concerned about or had an initial or follow-up visit that, some other things came up, those kind of things are reviewed with the physicians that sit in on and supervise in those meetings, as well as other nurse practitioners and the whole team. And so there's a lot of support for figuring out, how we might triage or think about risk analysis differently. But a lot of it is clinical decisions at point of care. There's no specific algorithm. We certainly went through, and Dana Lesbader was one of the first ones to develop the Optum model, where there was risk analysis based on data analytics to really figure out kind of dosing of visits. We've tried that several times. It really does come down to thinking about it from the IDT and what makes the most sense in terms of resource allocation of this very scarce resource of nurse practitioners in the home. I don't know if any of that's helpful, and I'm sure, Lindsay, you have better ways of phrasing.
Yeah, Lindsay, I'd love to hear your Lindsay, I'd love to hear your reflections as we kind of finish out today's session.
Yeah, I'll just give a couple Cliff Note things. And I think that was very well worded, Donna, or overview of the various challenges / opportunities. But I would say, one of the things that I had kind of stuck out in my brain is, and I would say we, Advocate Aurora's home-based palliative program, have consistently kind of gone back and forth on, or at least had a good, healthy discussion on as a team, and remain strong in, is any referral coming in, we do feel strongly that we do want to go out and assess the patient. I think, Marty, to your point about like who we would not take, I mean, there's certainly patients, we want to get out and get eyes on, because Epic is not the end all, which is our EMR. It's not the end all be all of this is the full picture of a patient. Right, wrong, or indifferent. There might be home scenario situations that might not be listed in there, or things that we know we can support on. So it at least behooves us to get out there and do an eyes-on initial assessment. We may not take the patient under care after that initial one based on, do they have a palliative need, and do we feel like we can, partner appropriately with the patient, and them kind of meet us too, as far as expectations of, we do want to see you. You will need to let us, come into your space, and have some of these discussions. And so I think that's a big piece for us, as far as being able to at least get in and see patients initially. And then again, if we don't feel we can have a great impact with them, or once they know more about the program, they may not be as interested. And that's okay. But at least we want our advanced practice clinician to get out there and have a discussion with patients to really suss out, is there something that we can help support them with? Because we always feel like there's at least something we could help from that standpoint. I will say, from just the geographical coverage and scheduling, I would say, if I asked anyone on my team if they had a magic wand, what would we solve for? And it would be geographical scheduling. And how do you optimize someone's day so they're not, driving to and from Timbuktu, but also they do have enough patients to see, and it is the most efficient, effective use of their time. And there's just really not a lot of tools out there right now that could, be a one size fits all. I think honestly we'll get there soon with some of this new AI, generative technology, and being able to help. We have X amount of patients in this area, and we know that, to kind of the point of, we do a clinical kind of priority of high, medium, low, and drives how often, or it gives a guideline for how often we want to see patients. Plot it out for me. What would that look like? How can I stay effective with my time? So right now it's a highly, highly, highly manual process. And what one person thinks is effective might not be what another person thinks is effective. So it's not perfect. I would say it's an area we're still trying to work through. But at least setting parameters of, here's an area, here's where we want to make sure that we're seeing patients. We've tried to assign zip code days. You can do it a host of different ways. It's a way that we have gone about it to work that through.
Lindsay, that's a great segue too, I think, to kind of as we finish this out. I mean, I think there's a piece of the spirit of what I'm hearing from you and Donna, and we all know a lot of creativity, a lot of kind of going in and trying new things, finding new tools. But, my view when I work with different programs and teams is like, you have to name those problems, and like naming that if you had a magic wand, like that's a great thing to say, what could we change? Because it does allow you to kind of focus, because it can get really kind of scatter plot going on, right? So how do you focus and try a couple of things? And sometimes it's just the answer is not going to be clear right away. You try a couple of things, you play around with it. Let me just summarize a couple of quick things. I think from a needs assessment, we said, the importance of it being an ongoing process, not a one-time event, but really critical to get started and throughout the process. And a lot of that's about those relationships. But as Donna talked about too, really drives the scope and other elements in Lindsay as well too. The care team design, the fact that it's not just the providers that are seeing the patients. There's a lot of full team, all team having to work together and thinking about that triage and intake and scheduling. And then that really big impact on care team design around scope of practice. And then a third theme around kind of operationally, which is, again, fundamentally, you're trying to figure out right clinician at the right time with the right patient. And that kind of constant process of stratification and tools to help manage things are some things to work toward. Just to kind of give everyone a little sense of our resources, again, Donna and I do a lot of work through CAPC. We actually both are on different office hours as well too, so we did list some office hours. So if you have more questions, if people wanted to come, please come to the different. We're not on all these, but we gave you a list of different office hours. But I encourage you to go to the website. There's a great home-based toolkit. In fact, Donna was one of the co-authors of a lot of what's up there on the home-based toolkit for CAPC. And then we've got a great, CAPC is a great online moderated community forum called Circles. And there's a calculator out there as well, too, a very simple tool, kind of a spreadsheet that just allows you to kind of go in and play around with some numbers. So hopefully those are helpful tools and resources. Lindsay and Donna, thank you so much for jumping on and sharing and managing it. And I'll turn it back over to, I think, Patrice to close us out. Or Marty.
Okay, well, thank you guys. This was a wonderful presentation with lots of information. If there are any other questions, I think we're over time now, but you can always send them our way and we can get them to our speakers. So thank you all so much for being here and have a lovely Friday.
Thank you.
Thanks.
Thanks
Bye.
all.